Thank you so much for joining us for our next lecture in our point of care ultrasound. So today we're going to talk a little bit about scanning orientation and needle tracking. So hopefully these will be a little bit more useful everyday sort of concepts that will help you guys out. Objectives for today's lecture is to identify how the planes of the body correlate to imaging planes, recognize the cranial, caudal, superficial, and deep objects on a longitudinal sonographic image, and recognize left, right, superficial, and deep objects on a transverse image. So I'm sure you're all very, very familiar with orientation. And when we're looking at planes, we're basically using the same planes you've been using since pre-med. So we're looking at the sagittal plane, which is going to divide our patient into right and left halves, and then our coronal plane that is going to divide them into our anterior and posterior halves, and then the axial or the transverse plane, which will slice them up kind of like a loaf of bread. So when we're in sagittal, when we're true sagittal, we're talking about being sagittal to the patient. So my transducer in true sagittal would look something like this. It would be aligned with the sagittal axis of the patient. Now, if I maintain that alignment with the sagittal axis, but I come off to the side, I'm still in sagittal, I'm just not in the mid-sagittal plane. So sagittal is when I'm maintaining transducer orientation that is parallel with the sagittal plane of the patient. Longitudinal, on the other hand, because kidneys and organs in the body typically do not lie in exactly a sagittal plane, we want to elongate them or look at them in their longest axis. So we have to rotate our hand so that we're off the sagittal plane in order to be in the longest axis of the organ. So when we're looking at our organs, we're really typically referring to our plane as long to the organ. If we refer to sagittal, it really kind of boxes us up into the terminology that we're staying sagittal to this patient, which is typically not true. Now this will come in, important when you're doing a lot of your central line placements or looking for vascular access, things like that. And so the arteries and veins are not going to necessarily lie in the sagittal plane. So most of the time you're really just scanning in long. Now, everything that we look at with ultrasound, if we see something in the long plane and then we turn on it and it disappears, that probably means that it's artifactual. So if I found something in the kidney when I was scanning in the long axis, I turned 90 degrees and scanned through that kidney, could never find it again. It probably indicates there was some kind of artifact. So in ultrasound, we really want to make sure that we see that we orient ourselves to the anatomy in two planes that are 90 degrees to one another to ensure that what we're seeing is accurate. So if we scan in long, as I demonstrated on the kidney here, 90 degrees to that would actually be axial or transverse to the part or the patient. If I was true axial, that would be keeping my hand exactly perpendicular to the patient. So most of the time we're really in transverse to the organ, just like we're in long to the organ, rather than sagittal and axial. You can be as picky as you want with that terminology. It's often used pretty loosely, but if you're having miscommunication, lots of times that may be why. Okay, and then coronal, we also can scan in the coronal plane, which would mean if this is the coronal plane, I would actually have the long axis of my transducer scanning into the patient with the beam going in such a direction within the patient's coronal plane. Now, when you go to grab on or hold your transducer, transducers will have a specific indicator that will orient you to how you hold on to it. Many of these transducers will have an indicator that looks something like this little divot here. That indicator actually not only works as an indicator to tell us what side of the transducer to orient towards the patient's head, but it also can act as a needle canal if you're trying to advance a needle in long in a line with the transducer. So this transducer here has that little canal for the needle. It also has another ridge right here. And when you're utilizing your transducer, you want to make sure that the ridge side of the probe or the needle side of the probe is going to be facing towards the patient's head if you're in long, and towards the scanning, the sonographer or physician or whoever scanning, if they are in transverse or axial. So marks go up towards the head and long, towards yourself in transverse. And you'll find after you've scanned a little while, if you get your transducer flipped upside down or something, it'll just feel like completely disorienting, because you'll be getting an image opposite of where you think you should be moving. All right. Now, holding the transducer has a number of different approaches, and with the considerations of musculoskeletal work injuries these days, they're becoming more ergonomically accessible or helpful. There's a few different recommendations as to how you hold it. You never want to hold your transducer up in this region, because it really limits the fine motor detail that you can accomplish with your hands. Most ultrasound, we're really making very, very subtle adjustments that make significant changes to the image. So if we're holding too far back on our transducer, we lose that control. The other thing you want to be careful of is not giving your transducer a death grip, which many of us, especially me, are guilty of. My right forearm is about 1 inch to 2 inches larger than my left forearm, because I would hold on to that transducer so tight. So be aware that you have to have a good grip. Sometimes gloves help. There are also ergonomic devices that can add a little bit of friction here to help you with your grip and things like that. So those are things you can look into if you're having any issues this way. One of the most recommended hand grips that you might want to look into using is the one demonstrated here by this sonographer. So you can see that they're using the 3rd through 5th digit here to kind of brace themselves or steady themselves on the patient anatomy, while maintaining a strong grip with the 1st and 2nd digit, so that they can get those fine motor details. And don't be afraid to rest your hands on the patient or support your arm if necessary, as the more support your hand has, the less you're going to wiggle or wobble or lose track of the image that you have, because your hand is sliding or shaking or something like that. Okay, so now when we are scanning, we have to think about the slice acquisition that we're obtaining. So in this example, the transducer orientation is going to determine the slice that we're getting. So if this is my transducer and the broad part of my transducer is like this, it's going to be emitting a beam that goes out like this. And so if my patient's head is up at this end, body is down here, this is going to obtain something that looks like a long or a sagittal axis slice of the body. So in this example, this person has their hand and the transducer oriented in the mid-sagittal plane, the long axis of the body, and because they're at the level of the liver, we're seeing an image that would represent something like this. The abdominal wall, the rectus abdominis muscles, the liver, the IVC or the aorta, depending on where they're at, pancreas, and pylorus. Here you see it on the ultrasound. So it correlates to reaching in, taking a slice of this patient and pulling it out and looking at it. And if I look at this longitudinal image of the patient's midline, everything to the left of the image is going to be caudal to the patient, or pardon me, cephalic to the patient. Everything to the right of my image is going to be caudal to the patient. Now everything towards the front of my image, the front is my skin line, so this would be the more superficial area, whereas the back would be the deeper area where you'd find the spine. So anytime you're in long, if you have your transducer oriented correctly with the notch or the indicator towards the patient's head, you will be taking a slice of the patient like this, cephalic on top, caudal on bottom, superficial on, or excuse me, cephalic on left, caudal on right, superficial at the top of your screen, and deep at the bottom of your screen. Now, if we were to transition that into a transverse or an axial, they're at this patient's midline, so we can call this an axial. They've turned so that the orientation of the transducer is cutting across the patient, which is going to be pulling a slice out of the patient, kind of like a slice out of a loaf of bread. Now, when we see how that's demonstrated, this is basically the same region we looked at on the last image, but by changing the beams slice, we're now getting a transverse cut or a transverse image of the abdomen. So here again, I still see the liver, I still see the aorta, I still see the IVC, but what I'm seeing is on the left side of my screen is my patient's right, on the right side of my screen is my patient's left. What's towards the top is going to be my patient's skin line or sternal kind of area, and what's towards the bottom is going to be my patient's spinal or posterior area. Now, this is only accurate if the sonographer or the operator turns so that that indicator on the transducer probe is pointing toward the person scanning. Now, the same thing goes with coronal. Here, this scan is taking a coronal approach, and you can see that this slice is now grabbing a slice out of the patient's coronal plane. So if we were to look at what this image would look like, it would probably show ribs at the top, then it might show right kidney, IVC, and then aorta. Because rather than going from the sternum back or the sternum down into the patient, we're going from the ribs across the patient. And that's a big difference with your coronal scanning. Now, coronal scanning works really well if you have a patient that has a lot of gas in their midline and maybe you're checking something with the IVC or the aorta or something, and you're getting a lot of shadowing through those vessels in the patient's midline. Coronal works really well to allow us to go around gas and then still obtain the image that we need to obtain. It also works as a good window or a good location to evaluate the right kidney, as well as if this person scanning were to slide that transducer upward, this would be the perfect place to get a right diaphragm, including the pleural space as well as the liver, looking for pleural effusions or something like that. Okay, so just a few examples here of our orientation. So this, I can tell this is a transverse orientation because I have my aorta sitting next to my IVC. So this is transverse or axial orientation where they've taken a slice out of a patient, kind of like a slice out of a loaf of bread. Everything to the left of my image is the patient's right. Everything to the right of my image is my patient's left. To the front of the screen, it would be, or to the top of my screen here would be my patient's sternal area. To the back of the screen or the depth would be towards my patient's spine. Now, if I stayed in the same location, rotated my hand 90 degrees, because we always evaluate everything in planes 90 degrees to one another, I can see now I'm in long. Here's my IVC lengthened out. Here is my liver here. Here is my pericardial space in here. And so everything that I have now turned to a longitudinal view, now I would see my patient's, to the left of my screen would be my patient's head anatomy or towards my patient's head, where to the right of the screen would be towards their feet. Top of the screen, again, I can tell that I'm accessing this right from kind of the substernal area. So this would be sternal region. Well, where back here we would see the spine if we were to go deep enough. And then this is just an example on a nice vessel. So On this vessel, you see it's lengthened out, it's long here. Here you see it in transverse. So those are 90-degree images to one another. This is looking at, say, a hose from the side of the hose. This is looking up the hose from the bottom end. Now, since a lot of what physicians and practitioners are going to be doing is needle placement or venous or arterial access, this can be really helpful. One certain note about trying to scan these vessels, we always recommend that you do any sort of vascular or especially venous compression in transverse, because it will just, you'd be able to see the whole vessel in there, compress it right before your eyes. Now, if you try and compress a vessel in long, odds are your transducer could roll off of the vessel. You'd think you compressed it, but you really just slid to the side of it. And so when you're using any type of compression to check a vessel, maybe looking for thrombus or something like that, you always want to do it in the transverse plane. Now, the reason I bring this up is because also if you're going to be placing a needle placement in, say, a vein, and you have it in long, because that vein is so small, so small in its size from left to right or medial to lateral, however you want to look at it, it's very easy for the transducer to wander off of it. And so you can lose your needle placement very easily. Whereas if you're in transverse, you're going to know that you're on the vessel. So some physicians and practitioners find it easier to do needle placements in transverse and then double check them in long, because you're staying on the vessel better. That brings us to scanning windows. So here's an example of a patient, and this could be the exact same patient, imaging the gallbladder. So here's a gallbladder, but you'd hardly recognize it because there's so much artifact in here that we can hardly even see what's inside the gallbladder itself. Now here, this is still not a perfect image, but you can definitely see that the gallbladder is anechoic, indicating, that it is filled with bile, not with maybe some sludge or something that this one may indicate. The only difference here is not really the patient, it's the window that the operator is accessing. So the best idea is to have, with some practice, you're going to develop an idea of which windows work for you. So for example, when I'm scanning the gallbladder, one of the places I will start with is going to my patient's midline and angling or rocking my probe so that the beam is scanning into their right lobe of the liver. And sometimes that works beautifully and I get a nice clear image. But sometimes they might have a lot of bowel gas in their transverse colon or something like that. And so if I were to do that on a different patient, maybe I wouldn't see the gallbladder at all. So my next go-to is to come at the midclavicular line and angle upward. And oftentimes you can get a gallbladder image there. Those would simply be using two different windows to assess the same anatomy. Another place with the gallbladder that can work is going in intercostal or in between the ribs. So that would be a third window. So you want to kind of think of these windows as different options within your toolbox. So if one option doesn't work out, you've got something else to go to and something else to go to next. You'll get used to having your favorite windows. Some people love to work intercostally, other people hate it. But you always want to know, if I can't see it, lots of times the issue can be addressed just by moving and trying a new window or accessing it from a different angle. Another thing that I had mentioned on our previous slide is that a lot of people can carry a lot of bowel gas in the center of their abdomen, and because of that, that bowel gas really slows down our sound waves and it basically destroys our image. And so one of the things that you can do is just be aware that you can guide those slices anywhere you want with just a very subtle movement of your hand. So just by moving to a new window, guiding that slice around the gas, you can still obtain information that looked impossible from a different window. Now that being said, all of my sonography friends would kill me if I were to pretend that you could always get a good image from just changing windows. Sometimes we are definitely limited by the patient habitus or bowel gas area or a number of different other things. So sometimes improvement's not possible, but much of the time it is, and being willing to try some different windows can really help get you some better imaging. Okay, so some of the common scanning windows that you might see, this is for cardiac. We use the subcostal, substernal, the intercostal, and then the apical view over here. So those are some of the good windows when you're looking for cardiac imaging. You'll also notice that the cardiac probes also have a very small footprint, meaning that the part that contacts the patient is quite small. Therefore, it's a little bit easier to get in between rib spaces here and here that you may not be able to get with a larger probe that we use for abdominal imaging. So here, and this is by no means complete, but here are some of our common windows for abdominal imaging. You might be able to get your pancreas, your aorta, your IVC all in this region. For the liver, you're going to be working your way around that inferior rib margin, maybe a little bit of intercostal scanning, maybe a little bit above the hip to see the kidney. You can check the pericolic gutters for any free fluid by just looking carefully in each of the quadrants. Check the bladder in the center and then this quadrant, and then you can access your tail of your pancreas, your left kidney, your spleen, all over here by this window. And when we show these windows really aren't just this one spot. You'd be adjusting this transducer forward around that inferior rib margin, possibly onto the patient's back if you had them roll into a lateral decubitus position. So it gives you tons of different options, and these are just some of the places you look. Nothing's really off limits. You do notice that they don't point out any windows right in this region, and that's because that descending colon really holds a lot of gas and can be really frustrating to try and work around. Okay, now another exam that you guys are possibly, especially the ER physicians, might be most interested in are going to be lung evaluations, or even like a FAST exam, which would be a combination of lung evaluation with abdominal assessment, looking for free fluid or bleeds or something like that. So here are some of the windows that you could use for the lung assessment. The easiest ones, and we'll be addressing this probably in upcoming class, but one of the things that you can look at in a lung is what they call A lines or B lines. And A lines are like an artifact that when I put a transducer about this region, right in the lower pleural space, or the just above the costophrenic angle here, and I took an image of the lung, it would create this artifact, and the artifact would make it look kind of like an A with different rungs down a ladder. And that would indicate that it had normal aeration. So just placing the transducer in that costophrenic angle area, we can look for this artifact, and it can really help us out. And that's one of the best windows to do that from. But you can look in other areas as well, kind of following it around, checking towards the mediastinum, checking at different lobes of the lungs, and even towards the apex. Transducer movements, I know we talked about this a little bit, but once you have a pretty good position, you feel like, okay, here's a liver in transverse. So this is transverse cuts of a liver. These are the hepatic veins dumping into the IVC up towards the dome of the right lobe of the liver. Now, the position of the sonographer or the practitioner's hand in this image is probably in transverse right about at this level. Now, if I were to move my transducer down, I'd probably run into a rib and lose this beautiful image that I have. But if I were to simply take my hand and just kind of tilt it or angle it inferiorly, I would angle down and get myself into the portal system here. And if I were to angle down a little bit more, I would get myself into a comparison view of the right kidney in the liver. So angling is one of the options where if you have a good window, and if you move up or down, you run into gas or rib or something else, you want to make sure that you're using angling to just scan through the anatomy without having to move into sub-quality windows. So that's really your tilting. I use that a lot. If you think about trying to view the heart from the substernal view, you're going to place your hand substernally here, and you'd have to tilt or angle up dramatically to see the heart up here. If you were to place your transducer right on the sternum, you'd see nothing because the bone would attenuate your beam. So using that tilting, especially in a couple of those circumstances, can be very helpful. Now, sliding, however, sliding can help keep you on anatomy. So one of the things that we see here, again, we're in the right liver, and you're seeing that we come into the right kidney here, and then we have a lower region of the right kidney here. If I were to have a kidney and I got a transverse cut of that kidney in this plane, and then I started to tilt, like we just talked about, tilt my transducer, it would get me some really strange cuts of that kidney. So on some organs, what you need to do is slide the transducer to maintain a transverse cut to that organ. So sliding is another important option for your transducer movement. Now, rotating is the next one I wanted to look at. Rotating a transducer. So let's say that I have my transducer, and it is, I'm looking to get a long image of the right lateral lobe of my liver here. But the way I have my hand positioned, the way I have my hand positioned, I'm actually obtaining more of a dome slice. So by rotating my hand, I can move this side of my transducer over and this side of my transducer over until I'm getting that cut that I'm looking for. So lots of times if you're really close to anatomy, say you have a vessel and you're not seeing the vessel lengthened out like you want to. You're seeing it kind of part of it open and then part of it closed, something like this. That's usually going to require just a little bit of rotation to lengthen out both ends of that vessel. So rotation is a very important movement. And then rocking your probe. So sometimes you'll have a part of anatomy that's not in the correct position on your screen. So for example, if I was trying, not as beautiful as this is, and I see the nice hepatic veins here, here. Let's say that wasn't what I was going for. Let me say I wanted to look at the left lobe of the liver. So rather than, I can't really slide because I'm going to hit the sternum. I can't really tilt because I'll lose access, or I'll lose contact with this end of the probe. So my other idea is to kind of rock my probe this direction so that it would move my image that way, an inch or so, and include the medial tip of that left lobe of the liver. So rocking can be very helpful to, to center whatever anatomy you're looking for on the screen. Okay, and this brings us to needle insertion. So needle insertion, as I mentioned, can be performed in the longitudinal or the transverse plane. So it depends, lots of times you might be doing your vascular access, other times maybe you're trying to do a fine needle aspiration. Either way, the object that you're trying to access can be identified in transverse or long, or sometimes both. So in the longitudinal plane, you would want to obtain the most central image of the target that you're shooting for. Most of the time you want to then make a needle trajectory of 30 to 60 degree angle in alignment with the length of your transducer. So you'd want it centered to your transducer and in alignment with it. So if this physician here were to rotate their hand at all, we would only be catching pieces of the needle rather than the whole thing. But if the needle is maintained right in line, right down the center of the transducer, you're going to end up with an image like this. Now, some needles may not have the same sort of reflective qualities as other needles. And so if you're having difficulty obtaining a really good reflection off of a needle, like in this case, it could benefit the practitioner to move their hand down and direct the beam perpendicular to the course of that needle to get a stronger reflection back. But lots of times your needles reflect very well, so it shouldn't be an issue. Now, as I mentioned in a previous slide, one of the challenges with this is these are very narrow vessels, and so it can be very easy to rock or slide your transducer off and get disoriented. If you do that, don't panic. If you know it was just there, just start sweeping back and forth until you pick it up again. People get tempted when they lose something to pick up their hand and make a large movement, but really just have trust that you had it, and just the slightest movement will get it back for you. Now, if this physician were to turn their hand 90 degrees here, you can see a transverse image of that same vessel, and now they're advancing the needle in transverse or out of alignment, out of plane with the image. And so you'll see the needle in this case, not as this nice long structure, but just as you'd see the tip on end. Okay, so just some really quick practice images here to look at, looking at the patient. If I were to see an image like this, I can tell that this is a diaphragm, this is a lung field, and obviously a large pleural effusion. So this would be probably obtained my patient's left costophrenic angle area in a coronal view. Now, this image, you can see the liver again here, and we see a large pleural effusion again. Not the clearest image, but then we see some lung tissue kind of collapsed up here towards the mediastinum. And then we see our rib shadows here, here, here. So this was most likely also obtained from that coronal, or possibly an off-axis sagittal right at that left pleural space. Now this, we see here some liver with obvious ascites here. This ascites fills up the anterior liver area. Lots of times you'll actually see the falciform ligament coming off of the liver, attaching it to the anterior wall when it's surrounded with ascites. So that's kind of helpful to look for. And then you see that there's enough fluid that it's even gotten into Morrison's pouch there between the kidney and the liver. And it looks like they have a right hemithorax with normal mirror artifact. So one of the artifacts that we'll start talking about next week is a mirror image artifact, which if I'm near a really strong specular reflector, I can have my sound waves come in, bounce off of something, scatter to a new direction, hit that specular reflector, and return home to the transducer. But because it was gone for a longer period of time, and because it came back to the transducer at a different angle, that transducer is going to think the echo came from deeper into the side of where it really came from. And so that creates a mirror artifact where we see a mirror image of the liver in the lung field. Now, if there were to be a big pleural effusion here, you wouldn't get that same kind of artifact, so that would indicate more normal lung tissue in that region. So this particular image was probably obtained in lung in this region, where they're seeing the pleural space here, the liver here, and that kidney and lung here. And that's a great access point to check for right pleural effusions and to look for any free fluid in Morrison's pouch or other ascites. Now here we're in the left lower quadrant in transverse, and you can see that there's ascites here with bowel contents floating around. And so this image was likely obtained transverse right at this level. Okay, this is looking at some ascites more in the pelvic region. So here you actually see a uterus in transverse, and you can see those suspensory ligaments holding it up and out to the pelvis. And we've got ascites collection in the posterior cul-de-sac as well as in the anterior cul-de-sac. So this would be a transverse image right above the pubic bone. Stay right there. Now, if this image, this is obviously a different machine, a different patient, but if the sonographer or practitioner were to turn to long on this same region, move the transducer to here, they'd see something like this, where you could see the uterus with fluid in the anterior cul-de-sac, fluid in the posterior cul-de-sac, and then bowel up here. Now this is an interesting one. Now in this image, this is our typical aorta, what we see if we're in the regular mid-sagittal plane in long axis. We see our aorta coming down. We see there's a celiac axis, there's an SMA, there's a little renal vein crossing under the SMA there, and then our aorta proceeds down. This image is up at the proximal aorta, kind of right in the substernal region with the transducer oriented in a long axis. Now this image you see is actually an aorta, and these are the renal arteries coming off of that aorta. Now you will only get this image if you are in a coronal view. Now I am seeing IVC and then aorta. That tells me that I'm scanning in a coronal plane where I'm going through the liver, through the IVC, and then through the aorta deep into my patient and getting a coronal view of that aorta demonstrating both branches of the renal arteries. Now, if I were to move back to the mid-sagittal plane longitudinal view, I would never see a renal artery in this image because I'm at midline to the aorta and the renal arteries are coming off the lateral aspects of the aorta. So that wouldn't be something I could pick up there. So this coronal view can be very, very useful in certain sort of applications. Okay, and then here we see this is just, this would be more of, I believe, a fine needle aspiration. So you see that they've found a mass here, a neoplasm of some sort, and it has a mixed complexity, meaning it has some solid looking components, some anechoic components, and some low-level echoes. And so they are following the needle inward. If they were not happy with the echogenicity of that needle, they could always adjust the transducer forward and angle it back so that it would be incidentating that needle at more of a perpendicular incidence. Okay. And then here's another one. This looks like I can see some thyroid tissue here. So here's a thyroid nodule. This is most likely transverse on the neck because you see that they are actually scanning off axis to the needle. So here's the needle tip coming in transverse to the scan plane. Okay, well, I know this was kind of a brief review. Hopefully there's going to be some useful nuggets in here to help with your scanning. If you have any questions, please let me know. In summary, sonographic imaging can be performed in longitudinal, transverse, and coronal planes to create three-dimensional understanding of anatomy. Alignment of the transducer with anatomy allows for assessment in the different planes. Lots of times our plane of our transducer is not going to be long to the patient's body or transverse to the patient's body, but it will be long or transverse to the patient's organ of interest. We also have to be familiar with the idea that in order to really ensure that a finding is real, is a true positive, we need to make sure that we're assessing that finding in two different planes at least 90 degrees to one another. Anatomy should be scanned to obtain a global understanding of the organ of interest. always before imaging just one certain area. So habit is when you see some really ugly pathology, the habit is to just focus on that pathology. And we teach our sonography students, and it probably would benefit any practitioner, that before you ever think about taking a picture, you're gonna, if you're looking at one particular organ, you're gonna scan through that organ first, getting your global orientation, taking stock of what's there before ever imaging or making any full determinations about what you're seeing. By focusing in on just one little component can really limit um, some of the benefits of the procedure. And ultrasound guidance can prove as a useful tool in needle and catheter placement. It gets more comfortable with more experience and practice, but it can be an excellent tool. So thanks for joining me today, and I look forward to the lecture next week.